There was a patient presented by Alice Shaw. This was published as a brief report in the New England Journal at the end of 2016, where they had taken an ALK-positive lung cancer patient, treated them as per the standard at that time, which was crizotinib. The patient seemed to have benefit but developed disease progression, and as we often recommend, the patient had a biopsy of their tumor. And in this case, there was a particular alteration that was found that should have predicted for sensitivity to lorlatinib, which is a new ALK inhibitor that's under development. The patient was treated with this drug, had a very good response in his or her disease, but then over time developed another resistance mutation. This was tested in a couple of different ways. And one of the interesting things that emerged was that this resistance mutation predicted actually for sensitivity for crizotinib again, which was the drug that the patient had originally progressed on. So they followed the logical route, gave crizotinib, and actually it did work quite well, had a quite dramatic response in the patient's liver metastases. And I think what this shows in a very nice fashion is a couple of things. One is that this use of preclinical data and importing it directly into clinical practice does work. The biology sorts out as we would predict. And so I think we can have some confidence that we should be able to do this in practice, absent any other better data that tells us what to do. And in addition, that this process is, as I had stated, a dynamic process. There is a push and pull to this. And so we can't be too dogmatic about things. We really have to move along with how the cancer is progressing to figure out what to do.